Good afternoon. Oh, that is quite a powerful microphone, and I didn't even press a button. I think we'll continue to have some people filtering in, but welcome to this breakout session, and welcome to those of you who are participating via the live stream. I'm Professor Brian Shannon. I'm a commissioner on the Judicial Mental Health Commission, as well as a law professor at Texas Tech School of Law, Rackham. It's my pleasure to introduce this breakout session and our speakers. The Texas Health and Human Services Commission began its Jail In-Reach Learning Collaborative just a few years ago in 2021 to support efforts to monitor and reduce the number of cases where defendants are found incompetent to stand trial in our county jails. Our speakers today will share with you some about the successes and challenges as this program has gotten going, as well as things that its participants have faced from its inception until now. Omar Hernandez is the Waitlist In-Reach Coordinator for the Texas Health and Human Services Commission, and Dr. Felix Torres is the Chief of Forensic Medicine, also for HHSC. And I'm going to turn it over to Dr. Torres to start us off.
All right, well, thank you very much, Professor Shannon. Hello, everyone. I'm Dr. Felix Torres, as was mentioned, and welcome to our presentation. It Takes a Village, collaboration across the continuum of care through HHSC's Jail In-Reach Learning Collaborative. I'm Dr. Felix Torres, a clinical forensic and administrative psychiatrist, and as mentioned, the Chief of Forensic Medicine for Texas Health and Human Services Health and Specialty Care System. And I'm here with the amazing Omar Hernandez to speak to you about this program of which we are super proud. Yeah, there we go. So these are the goals of our presentation today, to cover the evolution of the Health and Human Services Jail In-Reach Learning Collaborative, to learn about the Jail In-Reach Learning Collaborative structure, the goals and the services that we provide, to review the data and the overall outcomes from the first 3 cohorts, to discuss lessons learned over the last 3 years, and to contemplate how you too can apply a jail in-reach learning process in your community. Like other states across the country, Texas has faced the challenge of an extensive and growing wait list for inpatient competency restoration services due to multifactorial reasons, of course. On the supply side, census adjustments due to staffing issues, ligature risk mitigation, physical plant senescence, and then, of course, there was COVID. But also on the demand side, there's been an over-reliance on inpatient competency restoration, with year-over-year increases in the number of people added to the inpatient competency restoration wait list. I came on board 4 months into the pandemic, and among the many initiatives that our teams explored and put into place was indeed the Jail In-Reach Learning Collaborative. Here you see a little bit of the evolution. In the fall of 2020, state hospitals and behavioral health services began to collaborate on the exploration of solutions towards waitlist reduction and to identify activities that could impact the waitlist, the forensic waitlist, in a positive way. In April of 2021, the state forensic director, Dr. Jenny Simpson, and I began to hit the pavement, for the lack of a better term, proposing the Jail In-Reach Learning Collaborative to Texas All Access regional groups. It was really clear to us that in order for us to be able to impact and have an impact on the reduction of the waitlist, we needed to engage in a comprehensive approach, not only continuing to expand on our internal state hospital initiatives, but also working with our community partners and stakeholders towards that common goal. And so was born the Jail In-Reach Learning Collaborative. As you see, the first cohort kicked off on August 13th, 2021, and it brought together 12 local mental health authorities and their justice partners that included the judiciary, district attorneys, defense attorneys, sheriffs, jail administrators, and jail psychiatric providers to really work together to implement local strategies to actively monitor people within the county jails on the forensic wait list who were awaiting that state hospital admission for competency restoration services after having been found incompetent to stand trial. We just completed the training sessions for our fourth cohort, and as we internally call it, the boot camp. There have been a lot of lessons learned over the first three cohorts, and those lessons have led to the consistent evolution of the collaborative. For example, after the first cohort, we moved away from an LMHA-driven model, where the LMHA was the team leader, and we opened up the collaborative to any and all of the stakeholders to be able to apply to be the leader of the team and take the initiative to create their own county forensic team. Here you see the services that we provide. The Jail Enriched Learning Collaborative helps county forensic teams identify strategies to monitor people in county jails found incompetent to stand trial and who are awaiting admission for into the state hospital. Through the collaborative, we help to support planning and coordination across those county forensic teams, providing forensic service, consultations, clinical consultations, legal education, promoting that peer learning, which it's really important, and that networking across the participating counties, and then really formalizing a jail in-reach process to help enhance the existing jail in-reach efforts that are happening at the local level for those participating counties. There you will see a brief overview of what the structure of the Jail Enriched Learning Collaborative is. And I'm kind of breezing through this because I really want to get to the outcomes. And that's the part where Omar is gonna wow you. So the collaborative goes between the months of, for the most part, between the months of September and May. And it starts with a boot camp, as we call it, the 4 training sessions in the months of September and October, 2-hour training sessions. And then we go into the technical assistance calls, usually about 5 group technical assistance calls and 2 that are one-on-one between HHSC and the county forensic teams. And on the right, you will see some of the featured topics that we have covered over the first 3 cohorts and now into our 4th one, documenting jail in-reach processes, going through court-order medications, supporting and planning the relationship across your forensic teams. And then the bulk of the work, of course, happening is bringing in those requests for the services that we do provide, which can be seen here. So participating counties work directly with all of our teams, and this slide was turned in before some realignment in our teams, but now we're all the Office of Forensic Coordination. But the counties get to work directly with the Office of Forensic Coordination, Legal Services Division, and the Forensic and Jail Diversion Services on these services that we provide, all of course free of charge. Clinical consultations on difficult clinical cases, medication management, guidance on competency restoration, guidance on court-ordered meds, also on legal education, on legal statutory requirements, the court-ordered meds process, any alternate dispositions. We offer forensic services, free competency screening on individuals who may have some credible evidence of immediate restoration. We offer to screen them, and if there is such evidence, we offer free reevaluations, free trial competency examinations if the court does appoint us as the examiners. And we also provide guidance on expedited admission and maximum security unit waiver re-reviews, as well as collaborations and possible alternate dispositions, which we provide, of course, to any and all counties, not just the ones in the Jail Enriched Learning Collaborative, but we are always providing the additional information to our partner counties. And of course, the planning support, which is the most important part, the assistance in strengthening those county forensic teams and engaging the behavioral health and justice systems planning. And before I turn it over to Omar, here you see we are currently 46 counties strong. You see there the different colors, the different cohorts over the last 4 years. We began in August 2021 in yellow, as you can see, and each cohort has usually kicked off in the month of, well, the first one was August. After that, every September of each subsequent year, with the latest one in September of 2024. With each passing year, as I stated, we are really seeking to improve the quality of what we're offering and our ability to connect with and address the needs of the counties that are in the collaborative. We've recently, as you notice, shrunk the size of the cohort, and our hope that by decreasing it, we're able to better provide for more individualized support to the counties that we are serving and that we are partnering with. And now I will turn it over to Omar, who will go over some of the outcome data, tell you about the lessons learned, and talk to you about how you too can establish a jail enrich program in your counties.
First off, hi everybody. Thank you for the opportunity to speak to y'all today. I will resist the urge to click this thing. The child in me is like, ooh, a clicker, let's go. So in the first 3 years of the collaborative, what you see here is the total number of requests that our team has received for technical assistance. As you can see, with each passing year, the number of requests has grown as we've onboarded more counties, as well as just continued working with the counties already in the collaborative. These are just the number of requests our team has received. We've completed about 87% of them. Well, we did complete 87% of them. In instances where requests could not be completed, it was typically because the request was actually withdrawn by the requester, which could happen for any number of reasons. There have been a handful of cases where we've had to defer requests, and that's just typically because the topic of the request or the need identified within the request fell outside of our team's purview. And so in those instances, we would do our best to help those individuals connect with the appropriate department or entity or organization who could better address that need. As we saw in the few slides ago, we have 4 different service categories in terms of technical assistance we can provide. But by far, the most popular service category is fixed services. This request category comprises 90% of the requests that our team has received for assistance from the different counties in the collaborative. Excuse me. So on the screen, you can see what each individual service is within that category. And I'm just going to go through them real brief. Honestly, we could probably take up the entire rest of the presentation just talking about the individual processes involved with all 5 of these. But I'm just going to keep it real short. So the purple is our MSU waiver re-reviews. So these are in cases where individuals who are awaiting admission to a maximum security unit at a state hospital may no longer need that level of care. So we can review those cases to see if individuals can be waived to a non-maximum security facility. The next one is our expedited admissions in the burnt orange. Yes, that color choice was intentional for any college football fans out there.
Looks red to me.
Oh, dang it. Oh, that hurts. In this, for clinical reasons, we sometimes have individuals that are on the state wait list who need to move into the next available and appropriate bed ahead of others who are already on the wait list. And so counties can reach out to us to review these cases to assess that level of need. We will take into consideration multiple clinical factors to make that determination for that need. Our blue and green are the child competency quick screens and the child competency reexaminations. Using a screening tool developed by the state hospitals, we can assess individuals in jail who are awaiting transfer to a state hospital for competency restoration to see if there's evidence that they may have restored while awaiting transfer. And in cases where the court will appoint us to do so, we could then complete the trial competency examination for that individual or just directly by request from a county. These two requests can be done independently. They don't have to be one and the same. We've done both screenings and examinations for folks. We've also only done examinations for folks, but both we provide to the county and at no cost. Our last category is potential alternate dispositions. These are cases that can be referred to our team where individuals on the wait list may be better served in a less restrictive but still appropriate setting other than the state hospital. So our team can review these cases. We can consult with other HHSC teams and make recommendations to both the requester and legal parties for their consideration on appropriate steps or potential steps to be taken in those cases. We don't really know why this request is the most popular. We don't have a definitive answer to it, but over the years, our team believes that one of the reasons for this is that these requests tend to yield a tangible, easily observable, measurable result, especially because it can impact the wait list, which I will talk about here in a second. And we found that in doing this work that counties often will reach out to us to consult on these individual cases, and then that correspondence opens the door for us to be able to talk about other larger topics, such as operationalizing court-ordered medications, addressing barriers in connecting with other county stakeholders, and just other larger topics that may kind of come up for an individual county team. In terms of impacts to the wait list, we've had, in the first 2 years of the collaborative, we've had 54 individuals removed from the wait list as a result of jail in-reach services. This is typically due to individuals having received services in jail and treatment, and they may have restored while awaiting transfer to a state hospital. And so in those cases, counties have reached out to us to refer them for a quick screen or for a reexamination. In the instances where we've done reexaminations, the reexaminations usually have opined that individual competent to stand trial. We turn in a report to the court, and in almost every instance, I think there's been like 2 occasions where this did not become the case, but in almost every instance, the court tends to agree with our recommendation and they will declare the individual competent to stand trial and the commitment will be withdrawn, therefore removing the person from the wait list. We've also had 33 individuals who have been moved from a maximum security wait list to our non-maximum security wait list, or clearinghouse wait list, as we like to call it sometimes, after their case was successfully reviewed for a waiver. This often results in a reduced wait time to admit to a state hospital for services and for competency restoration. And that's primarily due to the fact that we have more non-maximum security beds in the state hospitals than we do maximum security beds. So these waivers have helped individuals more often than not get access to care a little faster. And lastly, there are instances in which individuals need to move ahead of others on the forensic wait list. And so through the collaborative, county forensic teams have been able to reach out to us to request assistance in discussing and assessing the needs of these individuals who are in active crisis. And in 41 of these cases, we have approved these individuals for an expedited admission. There we go. So those first 3 slides of outcomes were from our efforts to provide direct technical assistance to counties county teams have reached out to us to request assistance with cases. But through the collaborative, county forensic teams are formed and they are working to establish or enhance their ongoing in-reach practices in their county to monitor and manage the wait list. And so here you see outcomes that the county forensic teams in the first 3 cohorts of the collaborative have reported to us as a result of their participation in the Learning Collaborative. I won't read the whole table to y'all, but I did want to highlight a few. And so 2/3 of our county teams have reported that through the collaborative, they've been able to strengthen relationships between their own county stakeholders, as well as with us at HHSC. Over half have reported starting practices to collect data on their waitlist in their county, as well as establish practice to do regular multidisciplinary meetings to work together on managing and monitoring the forensic waitlists. Just under half of our counties have also reported establishing and or enhancing procedures for court-ordered medications within their county through their participation in the collaborative. And there's a whole lot more on the screen. And the work itself, while it's not, there's still ways to go for us. We're really happy with the outcomes that our county teams have reported. We've really enjoyed doing this work these last 3 years and continue to do so. For us, we feel that the work that we've done with these counties and the learning that's taking place for both us and within the county teams themselves will continue to contribute to helping us meet the needs of justice-involved folks in our state who are on the forensic wait list. And so that being said, through the first 3 years, we have had some challenges, some barriers, some lessons we've had to kind of learn along the way. And so the first for us has been communication. It's incredibly vital. Our work involves coordination between multiple entities at HHSC, as well as multiple entities within the community. We coordinate with county jails, LMHAs, judges' offices, DA offices, public defender offices, and maintaining consistent communication across all parties is absolutely essential to the success of the collaborative as a whole, but also for each individual county team's own efforts. And to go with that, we've learned that having stakeholder buy-in is absolutely critical. We need more successful county teams in the collaborative have been teams that have representation from all key stakeholder groups throughout the course of the collaborative. This is particularly evident to us when we engage in the individual technical assistance calls with our county forensic teams. Having representation from all parties as we discuss the specific barriers that those county teams are dealing with has been absolutely important. We have found that having one entity or one organization or even one individual in some cases be responsible for a county's in-reach efforts has not been particularly effective. It really does take a village. Outside perspectives have facilitated buy-in into our collaborative's efforts. Our teams at HHSC, I work with a lot of really smart folks. They're really dedicated to the work that we do, and they're just fantastic individuals. But we have learned that sometimes hearing the work being done by other counties dealing with similar challenges and barriers has an impact to our county forensic teams that we can't match. Hearing about folks that are, as some counties have said to us, in the trenches doing this work just has a whole lot of meaning and impact to when two teams as they try to engage in this work. And so as the collaborative has progressed, we have tried to make it a point to involve previous county teams from previous cohorts in our presentations and in our technical assistance calls, so they can share their experiences, their successes, their barriers with the current cohort. We've also at times connected county teams with previous counties who have addressed or are addressing similar issues or challenges that they have identified. And we found that being able to connect folks like that has really helped county forensic teams take larger steps in the progress that they're attempting to make in their own counties for monitoring and managing the wait list. Our informational resource bank, our collaborative takes place over the course of 9 months. We cover a wide range of topics, as you saw a few slides ago. We cover a wide range of topics, and it's a lot of information to manage. I'm on the team, and I sometimes find it hard to manage. So our team has really made it a point to make a centralized resource bank where we keep information, our internal processes, such as the waiver reviews, the expedited admissions, information on other crucial topics like court-ordered medications that we can have ready and available to share with individuals at their request. Last year, we also had our resources uploaded to the Texas Behavioral Health Justice Technical Assistance Center website. I think I got that name fully right. Yes. So we have that information online for folks to access as well. And we have found that it helps our county teams to have an easy place to get that information on demand, but it's also helped us be able to connect with counties looking to prospectively join the collaborative. Folks have reached out to us to say, hey, I found this information. Can I ask you guys some questions and learn more about what this process is, what you guys do? And so having that information readily available has really helped us be able to connect with folks. Speaking of connecting with folks, cultivating relationships with county stakeholders has been really important. Our more successful county teams are the ones where we've been able to engage with the team members directly, get to know folks, establish relationships with different stakeholders within that team. And this may be my own personal preference, but it's just nice to be able to have someone that you can call and to speak to directly when there's a question that comes up. I always love those conversations when folks reach out and say, hey, I just need to talk to you about something. I have a question. And I always love trying to help folks figure that out. I don't always know the answer, but I'll try to figure it out. But just having that direct connection to folks has been really important to us. And we have found that it's really made a difference when counties are trying to engage in their own in-reach efforts. It's been able to have someone to speak to and know personally on both ends. So, and lastly, and probably one of our biggest challenges is just maintaining long-term engagement. As I mentioned before, the collaborative takes place over 9 months. A lot can happen in that time, especially when we transition to monthly calls. A lot can change, and eventually the calls themselves end. And we found that a question kind of comes up with like, now what? Like, what happens now? County teams continue their work independently. Our team has to get ready for the next group of counties joining the collaborative. And so it's easy to sort of lose touch and kind of that and not maintain that connection that we've had with counties and help with those ongoing efforts. And so our team is really trying to make it a priority to try to stay connected with some of our previous cohorts, to reach out to them so we can stay connected, see what support we can continue to offer folks as they continue working within their own counties on managing and monitoring the wait list. And to that, we've also found that from the county side, sometimes maintaining engagement can be difficult. Folks sometimes, leave or organizations get restructured, or there's been a fortunate few cases where folks we worked with had funding that got cut. And so like they can't do certain things anymore. And so just navigating all that stuff and trying to stay connected so that we can keep that engagement going, so at least we can continue to have these conversations, has been one of our biggest challenges, but one we hope that we can continue to work on so that we can stay connected with folks as we work on this together. A question that comes up is, as a result of all this, is can you build a jail in-reach program in your county? And the short answer is yes, you absolutely can. That being said, when it comes to managing and monitoring the forensic wait list, it can be a bit overwhelming and intimidating at times. I definitely can understand that sometimes when looking at a big project, the first step is sometimes the hardest. What do? I want to do this thing, but I don't know how to even begin. So here we have some steps that we recommend to folks to take into consideration if they're looking to build an in-reach program in their county. We always recommend starting off with collecting data, getting information on your wait list, seeing what common charges appear on your wait list, what percentage of folks have what sort of charges, are there a lot of misdemeanor charges in your county, what kind of charges show up the most. They can sometimes point to potential points of intervention as counties look to see how best to address the needs of folks in their county. Identifying stakeholders, folks who can help and work together to manage the forensic wait list. Having a discussion on potential what options exist in your county. Is there a way to potentially look at assessing individuals to see if an altered disposition may be more appropriate for folks? What other steps can we take for these justice-involved individuals? And once these stakeholders have been identified, implementing regular meetings and identifying and clarifying roles and expectations amongst those stakeholders to see how you all will collaborate together on managing the forensic wait list. Some of these steps may seem sort of self-evident or basic in a way, but we have found that it's easy for some of this stuff to get blurred together, and having folks be able to take a step back and just look at each individual step within the process, within their organizations, and what their county can do or is already doing can sometimes help identify potential areas of improvement, where they can take further action. And so it's something where it may be self-evident, but as we've done this work for the first 3 years of the collaborative, it works. And so this is always our recommendation to folks when they look at potentially starting an in-reach program in their county. And if you are interested in doing an in-reach program in your county, we have a 6 steps guide. Over the course of the 3 years we've done this and worked with over 30 counties in Texas, our teams at HHSC have identified 6 concrete steps to starting an in-reach program in your county. The guidebook itself has information on each individual step. It also has information from other counties, examples on what they've done to implement these steps in their county, to provide context and examples for folks that could help. And we also have other appendices that can help guide the discussions as teams work together to start their own in-reach program. Helpful, almost like worksheets that you can work through as you guys discuss each of the individual steps. If you're looking for a copy of the guide, you can visit the link you see on the screen there. I believe we've also made the guidebook available to JCMH, so it should be available through JCMH as well. And lastly, you can also just email us. This is our team's inbox. You can reach us anytime if there's any questions about anything. We are 100% happy to help. And I don't just say that because my literal job depends on it. We are here to help. I'm always happy to have a conversation with folks. But you can reach us there too. And I think that's all we had. Thank you so much, guys, for giving us the opportunity to speak with y'all. And just wasn't sure if there was any questions or anything.
We've received a few questions online. I see one hand here. I'm going to take the privilege of asking the first. So of the 54 who have been removed from the wait list, do you have some further data? Like, were many of those because they stabilized on medication? Were there court orders that helped result in that? Or just curious.
Yeah, absolutely. So I don't have specific numbers with me, but in most instances, those individuals received treatment in jail, whether some of them were court-ordered. Counties have court-ordered medication processes in place, and so they ordered medications for individuals, and they did improve with treatment. In some counties, that may not have been the case, but they may have started medications voluntarily. They may have processes where staff within the jails or LMHAs are working individually with folks to provide them with treatment that has helped to improve their overall clinical presentation, which then sparked the question for the reexamination.
And with respect to some of the technical assistance on court-ordered medication proceedings, I know it's been inconsistent around the state. Some counties, that's fairly routine. Others have never done one. So are you training the prosecuting attorney or the court staff, or kind of what's some of that technical assistance?
So one thing that one commitment that we need to get out of the county forensic teams is that there needs to be a representative from each stakeholder at the table to be part of the collaborative. So we need judiciary, we need defense, we need prosecutor, we need sheriffs, we need jail administration, we need jail medical, jail psychiatric, to make sure that we are touching every single one of those stakeholders that touch the individuals. So yes, every single one of those individuals are in the trainings that we provide.
Excellent. At the back here.
Hi, not really a question, but we did use Jail InReach with our program, which is in San Antonio, Bexar County. We started the JBCR, jail-based competency restoration, and it was very helpful. We launched last year, and we've at this point have restored over 30 male inmates, and we're starting females next month. So, and we did work collaboratively also with Harris County in Houston. So it has been very successful for us, and I know we still collaborate with HHSC on things that we need, and it's working for us.
Terrific. And what's your county?
Bexar County.
Okay, excellent.
So
Go ahead.
we actually we had wanted to get Bexar County to be a collaborative member for quite some time, and we actually had a Jail InReach Light pilot with Bexar for a little while, where we were just doing reevaluations for Bexar County, and that went very well, and we were able to expand it into a full program, and then eventually Bexar County did join the Jail InReach, and they've been an amazing partner along the way.
Terrific. Let me alternate with an online question, and then we'll get to you. Is there a known or published number of people on the wait list with IDD, and how many of those tend to get removed because they're then deemed unlikely to restore? So I know we're generally not talking about medication in that space.
So I don't have a specific number that I can share right now regarding that.
Okay.
But the ones that we do remove some of the wait list and divert over to SSLC triage.
Okay.
But I don't have those numbers right now.
Okay, very good.
Hello. So I'm in Harris County, and of course, our wait list is terrible, right? And obviously, jail InReach happens. The first two prongs are pretty common for us, MSU waivers as well as reevaluation of competency. The other two, though, and this is all I do, competency restoration and NGRI. So I've never experienced an opportunity for either an expedited admission or, especially that last one you discussed, what is a less restrictive setting that could result in an alternative disposition. So what do you normally see that would result in an expedited disposition or an expedited admission to a state hospital bed, or what are examples of a less restrictive setting? Unless we're talking about like outpatient competency restoration, which we do utilize, but anything other than that.
Which one want to take?
I can start with expedited admissions. So for expedited admissions, there's many reasons why an individual may be recommended for or asked to be considered for an expedited admission. What we've seen the most is that the individual is not receiving sufficient treatment in the jail. There's not, whether it's because it's treatment resistant, their illness is treatment resistant, and they're on medications, but they're still severely psychotic, still chronically aggressive, posing as a danger to themselves or others. Sometimes some counties don't have the infrastructure to provide treatment to folks in the jail, which sometimes triggers those requests. They do the best they can, but their facilities just do not have the ability to manage those folks' needs. And so usually those are the cases where we most see those requests come through. As for, did you want to do alternative disposition or want me to do it?
So we evaluate those. We take every request for an expedited admission very seriously, and we go through a rigorous evaluation of the clinical information that we are provided, as well as we reach out to the local mental health authority and request a crisis assessment as the objective finding of the clinical needs of the individual out in the jail. With that information, my team gathers all that information, makes a recommendation to me. I review that information and I make the final recommendation to our associate commissioner whether to expedite the individual for services for an admission to the state hospital. They would go to the next available bed. And then on the alternate disposition front, it's mostly individuals who have neurocognitive disorder, dementia, IDD, traumatic brain injury, TBI, or have been deemed unlikely to restore. And we work with the court parties, the DA, to try to find an alternate disposition, and we work with our community partners to see if there is, for example, some services in the community that they could be diverted to instead of going through the inpatient competency restoration process. So it's like a dismiss and transfer at times, if there is that avenue available for them, depending on the charge, of course.
Okay, well, I'm getting the signal from the back and from our little counter here that our time is at an end. So please join me in thanking Mr. Hernandez and Dr. Torres.
Thank you.